back. This is Professor Sobha SIVAPRASAD from Moorfields. We'll talk about the possibility of PDR treatment with laser and anti-VEGF. Remember the days when surgery DRS suggested that should do only a pan-retinal photocoagulation for patients confirmed with the proliferative retinopathy. It had its own merit that it was easier to give and compliance was a problem. The compliance was not an issue. But anti-VEGF certainly has its own merits of preserving the visual field, but requires a little more expensive and more compliance. So let us see if we can combine the two or give separately. Sobha, for you.
Thank you, Dr. TP, and good morning, everyone. So as we said, I'll go through the pros and cons of PRP, anti-VEGF, or both. So these are my disclosures. So for proliferative retinopathy today, I will be only covering NVE, NVD, and pre-retinal hemorrhage and vitreous hemorrhage, not obscuring the fundus. So these are the ones where these three type of treatments are applicable. I'm not covering vitrectomy today. So as Dr. TP just mentioned, PRP is the standard treatment for PDR, no doubt about it. It is a very well-established therapy for over 4 decades. There's significant number of changes in technology, all for the better, to reduce pain, to increase the number of spot sizes. So the Pascal laser, the pan-retinal photocoagulation multi-spot laser, is very commonly used. At least in the UK, this is standard of care. I would say there is actually, with this, of course, there's less pain, easier to do, and faster. But the main problem is we tend not to give enough number of laser burns to the eyes, and therefore there is a risk of worsening of retinopathy if the retina is not covered completely. So coming to pros and cons of pan-retinal photocoagulation, the gold standard for treatment of PDR. Of course, the pros are it is a very well-established therapy. Field loss may not all be due to PRP, and I'll cover that later. It's of course, as Dr. TP said, it's low cost, and therefore patients are more compliant. And also we must think diabetic retinopathy is a global disease, so this PRP is, of course, makes it globally applicable for all countries to have, and it needs less number of follow-up visits compared to anti-VEGF therapy. Of course, the con is the insufficient laser treatment. In protocol INT, Susan Bressler had published that if you compare modern day multifocal or multi-spot laser versus single spot laser, what she reported was a worsening of PDR complications, more TRD, more NVI, etc. And the reasoning behind that was that because we apply less number of lasers. So yes, multi-spot is good, but we have to ensure that the area is completely covered. Field loss is of course a problem with PRP, but with these type of newer lasers that is less likely. There was a paper from Bradford in UK that showed that field loss is not a significant problem these days. There's of course increased risk of macular edema, other visual function losses, and of course laser causes irreversible damage to the retina. So there are loads of confusion about whether targeted laser is better than the usual scatter laser we do for PDR. There are few publications on this, none are long-term, and so far there is no difference in visual acuity, visual field, pain level, prognosis, or adverse events when comparing targeted laser to non-perfusion areas versus scatter PRP. So the conclusion to date is targeted laser is not needed, especially when you initiate treatment. Now, when we continue treatment and we do not know where to apply more laser, then perhaps doing a fluorescein and identifying areas of non-perfusion would be useful. Now, that's all about PRP. Now, when we compare anti-VEGF with PRP, of course, the protocol S is the study that gave us the most amount of data on this. So it was prompt PRP versus ranibizumab plus deferred PRP in PDR study. It was a generalizable study, so there are several advantages of reading up protocol S for if one wants to do anti-VEGF therapy. It included PDR patients with and without macular edema, and it has a 2-year primary outcome followed by a 5-year follow-up. It had a large sample size, and vision criteria is something we see in clinic. It was very broad, 24 letters or better. Treatment regimen was practical. The PRP arm allowed completing PRP in 1 to 3 sessions, and that's what we do clinically as well. Ranibizumab was allowed in both arms if the patient had DMO, and supplemental PRP was also allowed in both arms. So a really real-life situation. So what did we learn from the protocol as 2-year results? The retention rate was very high in the clinical trial. Visual acuity in the first year, ranibizumab arm did better than the PRP arm, although in the second year they balanced out. The field loss was of course worse in the PRP arm, but the regression rate of new vessels were very similar but edged better on the ranibizumab side. And then the DRSS2 level improvement was in about 50% of the patients. Ranibizumab showed improvement in DRSS level, and only 6% in the ranibizumab arm required supplemental PRP in the trial, while 45% required repeat PRP in the trial. Now, development of DMO, 35% required ranibizumab in the PRP arm at baseline, and another 18% required it over the 2 years. So these are the lessons we have learned if we are to do monotherapy. It is 2-year results, sort of okay, but we must then move on to the 5-year results. So this is the 5-year results, and here you can see that the visual acuity is similar in the 2 arms. So it's plus 2.5 in the ranibizumab arm if you had DME at baseline, and plus 3.2 if there was no DME at baseline. And you can see in the prompt PRP arm, it was very similar. Also, in the ranibizumab arm, they had to have 19.4 injections versus PRP arm where it needed only 5.4 injections. Of course, anti-VEGF in PDR over the 5 years did reduce the rate of vitrectomy and low incidence of diabetic macular edema, reduce risk of traction, and it's cost effective if the patient had PDR plus DMO. However, the protocol 5-year results did show a 40% dropout rate, especially in the minor ethnic group. So that's a very important point with long lapses between clinic visits. So now when you look at the 240 patients eyes that were left in the study, you can see the regression pattern is very similar between the ranibizumab monotherapy and the PRP arm. The DRSS improvement was similar to the 2-year results in the ranibizumab arm. Supplemental laser was again more in the PRP arm. Again, it only shows us that because we have to keep doing until we get complete PRP. And of course, all the other complications of PDR was less in the ranibizumab arm. So in conclusion, what you get from here is that by 5 years, there was not much change between visual acuity outcomes between the PRP arm and the ranibizumab arm. I said that I would come back to the visual field. So here, the blue line is the visual field loss you will get with PRP. And the yellow line is the one that you will get in ranibizumab arm censored after PRP. So you will see that ranibizumab arm also loses visual field over the 5 years. So when you say visual field loss, even for anti-VEGF patients, we need to consent them and say that their visual field loss will decline, and this probably is due to the continuing capillary non-perfusion that we see with anti-VEGF therapy. So then goes the Clarity study. This is a study we did in the UK. Here we compared aflibercept versus pan-retinal photocoagulation, and we did not include patients with macular edema, and it was a 52-week study. Here we found that aflibercept was superior to pan-retinal photocoagulation at week 52. What are the secondary outcomes? Here we found again very similar results to protocol S. We found very higher amount of new vessel regression, more number of patients became mild or moderate NPDR, and there were less incident macular edema, less traction, less need for vitrectomy, and of course very few injections were required after the 3 loading doses. An average of 1.4 injection was given over the 52 weeks. So all these are positive results. This is the type of appearance you will give. I'm sure all of you have seen that with anti-VEGF therapy. You see a complete regression of the new vessels. Looks very beautiful, as if we have reversed cosmetically a very good retina. However, we did a lot of post-hoc analysis on the Clarity study, and it showed despite the improvement in DRSS, there is no change or worsening of capillary non-perfusion, i.e. anti-VEGF does not have an effect on capillary non-perfusion. The venous beading also remain unchanged. New vessel discs are more resistant to anti-VEGF therapy than NVE, and it is not cost effective if you are treating patients with PDR without macular edema. This is the field loss that I mentioned. So the last trial that I want to mention is the Proteus study, which was a trial looking at a combination of ranibizumab plus PRP versus PRP. And here ranibizumab and PRP were given together at baseline and every other visit. So in a year, it's a small study, but there was a mean of 4 injections and 3 supplemental PRP after completion. And they also found a regression of NV, the visual acuity was better in the combination arm. So the question is, if we are giving anti-VEGF therapy, should we be giving PRP alongside? The PRIDE trial was such trial where they compared ranibizumab versus PDR versus combination. Again, a very small trial, 106 patients across the 3 groups. Here again, PRP was given in repeat sessions. Combination was first ranibizumab and then 2nd month combo. Again, same results, new vessel regression, more patients became NPDR in the ranibizumab arms, but recurrence was high. So in conclusion, yes, anti-VEGF does give better visual acuity and structural outcomes. However, the recurrence rate is high. We have to have long-term meticulous follow-up, which is very unlikely in our people with diabetes who have multiple comorbidities. So we have to be very careful not to put patients on monotherapy if you think they will not come back to us. It is cost-effective if anti-VEGF is given alongside in patients with PDR plus DMO. The UK practice is to give PRP if patients present only with PDR, and to combine PDR and PRP and anti-VEGF therapy if patients present with both PDR plus anti-VEGF. If a patient develops anti-VEGF after laser treatment, we still give them anti-VEGF plus PRP if required. Thank you very much.
Thank you, Sobha. Equally important that understand that laser or anti-VEGF will not take away your diabetes. So as long as diabetes is there, the risk is there of returning your new vessels or macular edema. Important to control diabetes biochemically and by other parameters. In India, also important to control anemia and hyperlipidemia. So patients would be informed that just because you are doing a laser or an injection or the combination, you have to still keep controlling your diabetes and then returning at least yearly or half yearly to follow up to the physician or the ophthalmologist.